how many times you see. It's always new every time, and I feel that same way. So I just wanted to kind of put this lecture together to just familiarize you guys with what we see in the emergency room and what we can do for these kiddos. Um, I have no financial disclosures. This is kind of our outline for the day. We'll talk about like the background definitions, epidemiology of what is going on with derm, our viral bacterial infections, cutaneous eruptions, ED disposition, and kind of some take home points as well. So, going on, it's hard to do this lecture without going over our basic definitions. Sorry, this slide is busy, but it just goes over every single, buzzword we use in dermatology. So, starting right into it, macules are non-palpable lesions. Usually, they're less than 1 centimeters. Papules, I usually tell my learners, if you close your eyes and try to feel over the skin, they are palpable. They're less than 1 centimeter. Plaques are the same as papules, except they are larger, they're greater than 1 centimeters. Nodules are also palpable. They can be solid or cystic. They are discrete lesions, usually 1 to 2 centimeters in diameter. Telangiectasias are dilated superficial blood vessels. Purpuras, there are two types of purpuras, palpable purpuras, which are raised, and petechiae, which are pinpoint and 1 to 2 millimeters in size. They usually do not blanch under pressure, and they represent extravasation of blood from cutaneous blood vessels onto the skin. Ecchymoses are basically larger versions of these purpuras. Pustules are again palpable. They do contain purulent material, so they're kind of yellowish in color. Vesicles are small, again less than 1 centimeters. They do look like clear fluid inside of them. Bullae are larger, similar to vesicles, except they are greater than 1 centimeters. Wheals or hives are irregular in shape. They are elevated and can be palpable, and usually they look different than the surrounding skin. Scales are flakes on skin surfaces. Atrophy is depression of the skin from the surface. Usually, there is a loss of the dermal or the epidermal layer of the skin itself. And then we have the different alterations in pigmentation. Hyperpigmented, which is increased skin pigment. Hypo is like decrease of loss of skin pigment, and depigmentation is complete loss of skin pigmentation. Going over the background of dermatology, there are a significant number of cases that present to the pediatric ED and outpatient. Children mostly have minor skin conditions. Very few subset of these people will require urgent treatment. About 3,500,000 patients less than 18 years of age present to the ER annually for skin and soft tissue infection. And just about 2% of all of them, of all of the ER visits can be skin related in the US. And there was this study which was done and published in the Pediatric Emergency Medicine Practices, where in the ED, there are about 1.2 million patients initially seen back in 1993. And now there is almost a threefold increase, 3.4 million seen in 2005. This was another study which was published in JAMA, which is a renowned journal, where it kind of shows you the skin infections, like there are what the percentage of patients presenting to the ED for these diagnoses. And usually, male and female are equally represented in this condition. The mean age was about 40 years of age. There was an overrepresentation at extremes of age. So, in the infant or the geriatric population, they came commonly for their skin conditions, and 75% were triaged as non-urgent or semi-urgent, only two of them having emergency status. Most of these patients got discharged, so 94% got discharged, and only 4% required inpatient admission. So, going over what viral skin lesions look like, I wanted to start off with this question. This is a 16-month-old female who has a history of eczema. She has a spreading rash over the last 2 days. She did have a fever of 100.6. She is currently taking medications for her acute otitis media. She's on amoxicillin. Her immunization is up to date, and she does go to daycare. These are more pictures of her hands and legs, and she has no oral mucosal lesions. What do we think this is, and what's the best treatment? I know I kind of started off saying this is the viral category, so actually, this kid needs supportive care, and she has hand, foot, and mouth disease. So typically, it is seen in the hands, feet, and mouth. And I also say it should have been named hand, foot, mouth, and butt because it also goes to the diaper region. This is what other lesions and intraoral lesions can look like for these kiddos. So it is caused by Coxsackie A virus. Usually, there is like a typical presentation, which were the pictures that we saw. They can have polymorphic vesicles, bulla, perioral skin involvement. They can have purpural skin lesions as well. Usually seen in the summertime, it is a fecal-oral spread. Usually it's self-limiting, and the course is 7 to 10 days. I do warn parents saying the intraoral lesions can get painful. The rest of them on their hands, feet, or mouth are not painful or itchy in these kiddos. Atypical hand, foot, and mouth. I just wanted to show some other pictures, which are not usually like our regular hand, foot, and mouth. In this condition, the intraoral lesions may be minimal. Sometimes they can have vesicular bullous or erosive eruptions in these kiddos. They can also extend beyond the palms and sole and can involve sometimes the perioral skin. They can favor towards those areas of eczema, or if they had prior skin burn anywhere in their skin, they can have purpura as well. Infants do present with large acral bullae as well. More pictures of hand, foot, and mouth. This is what we commonly see in the hands, where they can be macular or like flush to the skin. Sometimes they can also be papular, so we call it more maculopapular because it can be a combination of those two. Going to eczema herpeticum, this is seen in kiddos with an history of eczema. They kind of look similar to what the hand, foot, and mouth can look, except they do have vesicles. They are monomorphic and small, and they're like more uniform in nature. So going on to our next condition. So this is a 16-month-old healthy kiddo, worsening rash over the last 1 day and fever of 101. The kiddo also has cough and rhinorrhea and is refusing to walk. This kid is again taking amoxicillin for their acute otitis media. They have no blisters or mucosal involvement. Their cheeks are swollen, and the hand and feet are swollen. So I did want to point out, like, what is the most common diagnoses? And there is a bunch of options, and this is more of a serum sickness-like reaction. And I'm going to talk about urticaria, which kind of looks similar to our prior pictures, and then we'll talk about both urticarial reaction and serum sickness and what are the differences between the two, because they're kind of similar except for just one differentiating factor almost. So urticarial lesions are usually like giant or annular urticarial. They're benign hypersensitivity reaction. They can be annular or polycyclic urticarial lesions. They can have clear or dusky centers, and usually can also have soft tissue edema. Sometimes, like I mentioned, they could be mistaken for a serum sickness-like reaction. Um, Erythema multiforme, again, pretty similar to urticarial skin reaction. I just wanted to talk about all of these together because they look similar in pictures and in patients as well. Going over the differences between all of these. So an urticarial reaction, serum sickness, or erythema multiforme, they can have these like polycyclic wheals. And like I said, their centers can be ecchymotic. And then erythema multiforme is like more target like lesions. Annular urticaria is like not fixed. That means new lesions come on different spots. Serum sickness is more fixed, and erythema multiforme is also like fixed lesions. You can have facial and acral edema in annular tricharia. There is dermatographism, which I'll talk about more in a second and show you pictures what that looks like. The mucosa isn't involved, lasts anywhere between 2 days to 2 weeks. You can have low grade fever, usually starts off with viral symptoms. And sometimes kids can be on antibiotics because antibiotics can trigger it. It's not an allergic reaction, it's more an hypersensitivity reaction. And that's what is key for education for these parents as well. So, going on to serum sickness like reaction, this is the first case that we saw, the first picture in that case. This kiddo did have joint swelling, and that's why they were not weight bearing, and that's their key difference. They can have high grade fevers. They kind of are a little more sicker in appearance. They have arthritis and lymphadenopathy, can have an antibiotic exposure. And like I said, the key thing for the serum sickness like reaction is their joint swelling. Um, Moving over to what erythema multiforme looks like, it's more like target like regions. It can happen more in the acral distribution. They are fixed lesions, and mucosal involvement is there most of the times. They go on for a little longer time, 2 to 3 weeks. They can have low grade fever, mild itching or burning sensation, and HSV can be a trigger in these kiddos. Again, pictures to differentiate the three. Annular urticaria, they're kind of more hives like, they don't have like a discrete appearance. Serum sickness like reaction, kind of similar to your urticarial skin reaction, but they do have swelling of joints and feet. And then erythema multiforme is more of this like target appearance where you have that hyperpigmented spots right in the middle. You can have mucosal involvement as well. Um, Erythema multiforme, like I said, you have that classic target-like appearance. They're fixed. They can be more symmetrical, and there'll be stuff in the mucosal region. Um, a tracherial reaction can move. They can have like three distinct zones. They can have like a darker center or blister or crusting. There can be a pale ring of edema. There can be a red outer ring as well. More pictures for us to look in and differentiate what of these like pretty similar lesions look like. And then you have these tricharia multiforme. They can have this like dusky appearance in the center. They do fade away slowly, and sometimes the blue-gray region of purpura and petechiae can be seen more with vasculitis. Going back to serum sickness like reaction, again, going back to our clinical vignette, the child won't bear weight because they have this arthritis. They can have a medication exposure, usually higher fevers, lymphadenopathy. They're kind of more sick appearing and have arthritis as well. Um, Again, more differentiation between a tracherial reaction and serum sickness. The skin lesions do look pretty similar, but again, harping on about the arthritis and higher fevers in these kiddos with serum thickness like reaction. Um, I was talking briefly about dermatographism. This is what it looks like, where if you write or draw on a person's skin, they can wheel up, and that's what that's called. You can just use one of the tongue depressors to kind of make scratches or lesions on their skin, and that kind of stands out and can help you make the diagnoses as well. These are self-limiting, usually lasting between 2 weeks, up to 2 weeks, anywhere between 2 days to 2 weeks. You can stop any unnecessary medication. If it's a medication trigger, it's not a true allergic reaction to the medication. So it is okay for the patient to continue it for otitis media or whatever else they're getting this antibiotic Four, treatment is usually a non-sedating antihistamine, cetirizine, sometimes the Benadryl because the H2 works a little better. I do recommend that more at nighttime, or every 6 to 8 hours as needed for breakthrough lesions. So it is a hypersensitivity reaction. Common trigger is viral. Those lesions can be annular or wheals. They can have these centers which are blue-gray or dusky in appearance. They can have edema of their face and hands and feet. Treatment is antihistamines. Usually, I warn the family around the clock. Once the antihistamine weans off the body, the lesions can appear. So the key is to keep at the medications round the clock. Moving on to more bacterial skin infection, like you guys may have already guessed, Staph aureus and Strep pyogenes are the most common of these conditions. And then you have the H flu in the pre-vaccination era, or if they have facial cellulitis in less than 2 years of age. Strep pneumo if they have facial or orbital cellulitis. Actinomyces are usually seen in oral, pulmonary, or intra-abdominal injury. Pasteurella is seen in like more animal bites. Pseudomonas is seen as hot tub folliculitis. Um, Going over another case, there is this 2-year-old who has a rash on her face. Mother knows that the rash had started 3 days ago, after the child sustained a cut on the inside of the nose. She notices that the child keeps to be in pain, and she keeps touching this rash and keeps frequently rubbing her face. Afebrile, no other associated symptoms other than nasal congestion. And then the physical examination is that picture that shows, and she is noted to have honey custard lesions around her face and her upper face and her lips. The medical student is asking you what this rash is and how to treat it. I think honey crested lesions is the buzzword for impetigo. It is highly contagious. It's a common bacterial skin infection, usually seen 2 to 5 years in the younger age group. Equal incidence in males and females, usually seen in hot, humid climate. There is a prevalence of impetigo that varies seasonally, and then there is peak incidence during summer and early fall. Right about this time, you can see more of these. There are two types of impetigo. You have the non-bullous, which is kind of like more like crusty, patchy, classic honey crusted lesions. And then you have these bullous impetigo, which are kind of yellowish and honey colored, but they are bullae, so that you have that fluid-filled blister appearance in these kiddos. Um, Treatment, usually to compare the two, this is more Staph aureus, bullous impetigo. It can, it's more classic in the neonatal young infant. Their thin wall lasts for 2 to 3 days. They can have like these honey crusted lesions. They can extend with central clearing. Usually the complications are rare in bullous impetigo. In the non-bullous impetigo population, they're seen more in like school age children. They do have these honey crusted colors. They can extend peripherally as well. These can get a little more complicated, like cellulitis. They can have the post-streptococcal glomerulonephritis, and a little more extensive complications just beyond the skin as well. Treatment, usually we try to treat the organism that causes the infection. So penicillin, dioxycyllin, cephalexin usually is the treatment choice for both pediatric and adult population. And this is more like a weight-based dose cheat sheet to kind of go over the treatment of impetigo. Folliculitis. Our next big thing is just the infection around the hair follicle. This usually presents with an erythematous base, and you can see the hair follicle right in the middle of it. These can be painful, can have like that tiny little purulent drainage, and can also present with fluctuant nodules. Staph aureus is usually the common cause of this, but if you have hot tub folliculitis, Pseudomonas can be more a cause for this infection. So Moving on to a little more complicated ones. Furuncle and a carbuncle, they're more infection of the hair follicle, but they do extend beyond the dermis into the subcutaneous tissue. And carbuncle is more of an inflammation process as well around with purulent drainage. Both of these have more systemic symptoms. They can have fever and malaise in the population. So this is going over all of them together. Folliculitis is usually tiny, 1 millimeter perifollicular pustule or papule. They do occur in areas of sweat and abrasion. Like I mentioned, the antibiotic choices for folliculitis can be erythromycin or tetracycline. When you are thinking more of a furuncle, it is a little larger than what a folliculitis looks like. Depending on the size, you may need to do an IND. Dioxycycline is usually a choice, or augmentin is a good choice of antibiotic for these lesions. Carbuncle, they are little bigger than the furuncle, so it's like more intense. They do have more systemic symptoms. IND and antibiotics is kind of the treatment choice for this as well. Going over a little more extensive of the skin and soft tissue infection, we have cellulitis. This is a non-necrotizing inflammation of the skin, again caused by Strep pyogenes or Staph aureus. You do have some other rare things causing cellulitis. Usually, you have the typical warmth, erythema, pain, and swelling. Usually causes after a break in the skin, like if they have a cut or a laceration, tear or a fissure or a bite mark or even an insect bite can trigger it. Any break in the skin can be the origin of these. Sometimes you are able to see that tiny little insect bite as well on the skin. Moving on to more pediatric thing, orbital and periorbital cellulitis. What that looks like, periorbital cellulitis, again, the similar organisms cause it. It is usually by local trauma, insect bites, or local infection that is causing the infection, and it's more presented with like eyelid erythema. And then orbital cellulitis is infections involving more the orbital tissue, where there is a more emergent need for treatment for these people, where you have infection and inflammation of the soft tissues posterior to the orbital septum. So, orbital septum is an imaginary line that kind of divides the eye into two, and any infection in front of that septum is pre-septal or pre-orbital cellulitis, and any infection of the soft tissue beyond it is orbital or post-septal cellulitis, and that one can occur more from complications of sinusitis. This has more systemic symptoms. You can have fever, pain with movement of your eye. They are managed by IV antibiotics, and usually we talk to ophthalmology team as a consult on these kiddos. Again, differentiating between the clinical symptoms, both of them can present with eyelid swelling and edema, but there is pain with movement of eyes in orbital cellulitis and fever. Proptosis can be present in orbital cellulitis, and diplopia and more vision changes may be present with orbital cellulitis. So it's more severe and would require IV antibiotics. Moving on to abscess, it's more of a localized collection of pus, kind of a progression from cellulitis is what I would call it, because there is collection of pus within the dermis or the subcutaneous tissue. They present as painful, fluctuant lesions with or without surrounding cellulitis. Usually, the management is like drainage of this purulent material. Patients can also have symptoms of fever, chills, and other symptoms of systemic toxicity as well. Again, going over the organisms, Staph aureus is like the most commonly cultured organism. Sometimes they can have anaerobic bacteria that's causing this. It can occur in any part of the body, but most commonly found in the neck, axillary region, gluteal region. Usually, IND is necessary to drain the abscess. Sometimes the abscesses are sterile. Most of the times they contain bacteria. For IND, if you are doing adequate length and depth of the clearance. Sometimes you can get away without antibiotics, but sometimes we do an IND and put the patient on antibiotics as well. Um, just because I practice more in the emergency room setting, we can do an ultrasound of these lesions, and that can help us determine if this is an abscess versus cellulitis. And I'm going to show you pictures what those two look like. So ultrasound is a pretty sensitive modality to diagnose abscesses. It's easily accessible. It doesn't have any radiation, so it's quick and easy to perform. And for cellulitis itself, it has this classic cobblestone appearance where there is no hypodense lesion or like a pocket of fluid. This is all cellulitis that is seen in this picture. Moving on to the next question, we have a 5-year-old which presents to the ED with a rash starting on her face and then spreading to her neck, axilla, and groin. She has had a recent upper respiratory infection 1 week ago. The patient's rash is tender to touch, and which of the following is uh, common for this condition? This is actually a disease caused by an exotoxin producing bacterium, and I'll talk about what that looks like. So, what they're trying to describe in that question was that it is a staphylococcal scalded skin syndrome. It is again caused by Staph aureus. It is an exotoxin producing disease where the exotoxin kind of breaks down the skin and causing the detachment or what we call the Nikolowski's sign. Usually can occur in newborn, like 3 to 7 days of age, young kids. They are a little more sicker, fever, irritable, because these blisters or these lesions can be extremely painful, and they kind of peel off even with like gentle touch or mechanical stress. Sometimes these people can have conjunctivitis. Usually, we kind of, because their skin layer is peeling off, we do supportive management like fluids and then antibiotics like nafcillin or oxacillin. If there are having resistant organisms, we can consider vancomycin IV for these patients. So there is like different types of toxins which can cause different skin conditions, and we're specifically talking about staphylococcal scalded skin syndrome, which is the exfoliotoxin A and B, and that's kind of manifested as different diseases. In the newborn, Ritter's disease. In the infants, you have the scalded skin syndrome. Older children, you have staphylococcal scarlet fever. Bullous impetigo and bullous varicella are local toxin production as well. So, going on to the incidence of this, about it can affect about 30 to 50% of the healthy children are colonized with it. 0.13 cases in 100,000 is the incidence of this. Usually there is colonization in the throat, axilla, perineum, and rectum. It can occur in neonates and children less than 5 years of age. They can cause outbreaks in nurseries and the NICU, just because of the asymptomatic carrier that it can even spread from the NICU staff. So usually there are about 50 official reports of scalded skin syndrome in adults documented in like 2014. Again, this can be a spread of infection in and cause more systemic symptoms as well. You can have like a local site of infection, circumcision site, the umbilicus, throat, or the skin infection. They can spread through the bloodstream. At that point, your blood cultures can be positive, but usually in this blood cultures are negative, and then they do have these like bullae which are intact and can easily also disrupt. So This is how extensive the Ritter syndrome can be. And then you have pictures of bullous impetigo that I spoke about earlier in the lecture. And then staphylococcal scarlet fever is more patchy lesions everywhere in the body. And then bullous varicella, just like other exotoxin A and B causing lesions in kids. They can present as macular erythematous rash. They can have like a prodrome of like another skin infection, like impetigo. They can have preceding fever. Malaise kind of generally irritable and fussy because the skin is so tender. Rash kind of begins centrally and then spreads around. Even gentle traction on the skin can cause the skin to peel off and blister and form blisters in this kiddos. Again, early diagnosis is necessary just because of how critical these babies can appear. We do recommend nafcillin, oxacillin, fluoxacillin, and then if you have a penicillin allergy, you can consider other antibiotic choices, or if they are critically ill, if you have concern of MRSA, or if they're not improving with the initial antibiotic choices, consider vancomycin on these kiddos. Um, Usually, the steroid use in this condition is controversial. We don't really use it. Sometimes fresh frozen plasma can be used in kiddos if there is a large area of involvement. Um, Remember, these conditions are pretty painful, so pain control is like an important step. Again, if you are losing skin, that is a way of insensible water loss for these kiddos, so that they do need IV fluid and wound dressings, and talking to either burn or wound care team is appropriate in this population. Going more to necrotizing fasciitis, it's more aggressive than the staphylococcal skin infection. It is uncommon in kids, but can occur after trauma, surgery, or if they had varicella lesions. It does spread across the fascial planes. They may not have any overlying symptoms of cellulitis, so that can be tricky to diagnose, and usually pain is out of proportion for the physical exam. This is the facial planes. This is more of the normal anatomy. And then you have the green one is like the initial skin in the fascial layer. And then you have spreading into multiple layers. That's like more of your late stage or stage three, where you have tissue necrosis, hyposensitivity, anesthesia, and tissue crepitation. Prompt surgical evaluation is recommended. Necrosis constitutes to a barrier for penetration of antibiotics, so surgical debridement is crucial. Usually, they may need to go to the OR within the 24 to 36 hours for further debridement. These patients are started on broad spectrum antibiotics, vancomycin, Zosyn, which is piperacillin tazobactam. Sometimes, if there is a monomicrobial infection, penicillin plus clindamycin is necessary. Um, Debridement is no longer, when the debridement is no longer necessary, or if the patient has been afebrile for greater than 48 hours, and if they're clinically improving, that's kind of when we stop the antibiotics for these patients. Moving on to the next spectrum of things, toxic shock syndrome. This kind of is a pictorial representation of what this patient can look like. They are more severe and have systemic symptoms like headache, fever, confusion, sore throat. They can have non-purulent conjunctivitis, lethargy, vomiting. They kind of have this like sunburn like rash. They can have epidermal sloughing of palms and soles, usually associated with the tampon use. And they can also have like more rapid progression of these symptoms within 48 hours, and can get as sick as having hypotension, syncope, and shock as well. Again, it is toxin mediated. Usually, Staph aureus or Group A strep is the cause. You do have this toxic shock syndrome, toxin type 1, toxin that usually causes it. They, make the lymphocytes active, and there is a massive release of cytokines, which cause the more severe symptoms of toxic shock. Again, the diagnosis is made with at least two of the following lab tests or clinical findings, where you have your creatinine more than two times the normal, thrombocytopenia. You can have like elevated liver function, acute respiratory distress, or a generalized rash that may desquamate as well. So the management is fluid management, pressure support if your patient is hypotensive, and in any foreign body, including tampons, nasal packing, anything that could be the source of infection should be removed. Penicillin plus clindamycin usually takes care of this situation. Sometimes in very severe toxic shock syndrome cases, IVIG may be beneficial in reducing mortality. Moving on to more other types of skin conditions, more cutaneous eruptions. I'll be talking about Steven Johnson syndrome and toxic epidermal necrolysis, or TEN. They are again in the same spectrum. Steven Johnson syndrome is usually when less than 10% of the body surface is affected, and TEN is more than 30% of your body surface is affected. Again, talking to the burn or wound care team in these conditions are helpful and improve the prognosis of your patient as well. They are type 4 reaction. Again, like I said, they're the same spectrum of disease. There is the main difference, like I mentioned, is the body surface area involvement. And where there is an Steven Johnson syndrome TEN overlap when you're right in the middle, when you have 10 to 30% of body surface area involvement. This is again another busy side, which kind of goes over the pathogenesis and the clinical finding for this condition. Um, multi or multi fold causes. You can have drugs, lupus, infection, immunodeficiency, or genetic predispositions can cause this. Drugs that are commonly associated with SJS are allopurinol, carbamazepine, phenytoin, lamotrigine, any of your anti-epileptics, sulfonamides. They can have anywhere between 48 hours up to 4 weeks of introduction into the body. These can present as SJS. So again, SJS is less severe. TEN is the extreme end of that spectrum. SJS is less than 10%. TEN is when you have greater than 30%, and then you have this in between where there is 10 to 30% when there is overlap between the two. Some viruses like mycoplasma and herpes can also be tagging team along with SJS and TEN. You do have specific genetic factors that can affect it, and then immunodeficiency like HIV and malignancy can also worsen these conditions. Sometimes if you have exposure to radiation or UV exposure, they do increase the risk of these conditions as well. Again, more pathophysiology of what is truly happening in like a more molecular level in these conditions, where you are seeing the drug and the cytokines releasing, different drug activated monocytes are there, and that causes more reaction and symptoms. These are more pictures of what this can look like. Steven Johnson syndrome may have minimal mucosal involvement, and the more mucosal involvement occurs, it can be more consistent with toxic epidermal necrolysis. Um, again, early symptoms, you can have these rash, non-specific. Late they can transition into vesicles or billa as well. You can have the positive Nikolowski sign. They can have mucosal involvement. Obviously, discontinuing the offending agent is the key. Fluid replacement, IV fluids, similar to what a burn management would be. Aggressive fluid hydration, nutritional care. It is good to involve ophthalmology in care of these patients because they can have ocular involvement. And then patients can be treated with steroids or IVIG can have better outcome. Going over a clinical pathway of how to manage these skin and conditions, just generally any skin condition in the ER, what we look for and how we can decide the safe disposition of these patients. Our first question is the patient systemically well? Are they less than 3 months of age, or are they immunocompromised? If the answer is yes to any of those questions, is there pain out of proportion to exam, then we kind of consider necrotizing fasciitis. You have to talk to our surgery colleagues emergently and start them on broad spectrum IV antibiotics. Um, and that's kind of going over those three main questions of, is there pain out of proportion to exam? Then we need to be more aggressive in their management. Um, Moving on to periorbital erythema or edema, if there is presence of pain with eye movement, if the answer to that question is yes, then we do an orbital CT to evaluate for orbital cellulitis and start them on IV antibiotics. Um, and if it is not, then we are more concerned about preseptal, and that can be safely managed with PO antibiotics. Moving on to the next condition, if there is areas of erythema or tenderness, then is it like clearly demarcated versus not? If it is well demarcated, then it's more erysipelas and can be managed with PO antibiotics. If they're not well demarcated and have these streaking, more like cellulitis appearance, then you may want to broaden the antibiotic choices for these patients. Moving on to the last one, if you have crusted lesions, are their bases eroded and heaped up margin? If the answer is no, then it's impetigo. You can consider oral antibiotic choices for these patients. And then if the answer is yes to that question, then it can be ecthyma and it's treated with mupirocin. Again, I just went over the disposition of these patients, but most of these are multifactorial. If there are special considerations to take on these patients, where if you have any signs of systemic infection, any medical condition that causes poor healing, location of the infection, and obviously reliability of the family to provide care and follow up is also one of the big things about disposition of these patients. Um, People who are at more severe risk of infection or overwhelming infection is the immunocompromised patients, or neonates, or if you have neutropenia or immunotherapy, cancer, those kind of patients. Anybody who has failure to outpatient therapy, or if they're already trialed on PO antibiotics, then they may need to get admitted. Location itself, if it's in the face, hand, groin, they may require more closer observation because those infections tend to progress and spread more. If the area itself is like large and not responding to oral medications, or if they have systemic signs, obviously, if they have hemodynamic instability, their altered mental status, vital sign instability, all of those are indications for admission. And the last three, especially if they are more ill appearing, that is ICU level of care. Going over take home points of what we learned today. Like I said, there are a large majority of patients who show up in the ER. Only about 4% require inpatient level of care. Most of our viral lesions are supportive care, antihistamines, and no antibiotics in this population. And then bacterial, obviously, we're targeting the causative organism, usually Staph aureus and Strep pyogenes. We went over the different definitions, what a macule, papule, vesicle, what is palpable and what is not, and then the extensive SJS and TEN, where SJS is less than 10% of your body surface involvement, TEN is more 30% involvement, and then ED disposition. We talked about who needs to stay in the hospital, failed outpatient, if they're more critical, if they have more severe signs and symptoms of hemodynamic instability, altered mental status, vital sign instability, then they need ICU level of care. That kind of goes over a big overview of all of our dermatological conditions, and these are my references. And I'm happy to take any questions if you guys have any.
In the meantime, I will go ahead and post the link for the evaluation in the chat, and you are welcome to fill that out, and I will get you your CE certificate. If you think of any questions afterward, you're welcome to email me, put them in the chat, or email. I think Jamie's in here. Any of the outreach people or pediatric people you see in here from UMC, you're welcome to email any of us, and we'd be happy to answer them for you guys. Thank you again, Dr. Krishna. It was a wonderful presentation.
Thank you so much. I appreciate it.
For now, I don't see any questions, so we will go ahead and turn you guys loose. Thanks again, Dr. Krishna, and y'all have a wonderful day.